All right, we're going to be going over the recently updated traumatic arrest protocol along with hydralazine that's being added as a antihypertensive medication. So we're going to start off with a case review. So you're dispatched to somebody who suffered a gunshot wound. When you arrive on scene, it's an 18-year-old male who has a gunshot wound to the chest. There's an entrance and exit wound. Bystanders report that he just stopped breathing, so it seems like somebody who hasn't been down for too long of a period of time. And when you get there, the engine has already made scene before you, so they're already doing CPR. So you're walking into a situation where CPR is already being performed, so you're trying to assess the scene and the situation. And you place the pads on the patient and they're in PEA. And I want you guys to think, what are some common things that could cause a patient in traumatic arrest to be in PEA? Hopefully the first thing that you can think of is blood loss. That's probably the number one thing that's going to kill most patients in traumatic arrest. The second thing could be tension pneumothorax, especially if there's any trauma to the thoracic area. Cardiac tamponade, which is a strong thing that could be happening right now, considering there is a gunshot wound to the chest. We don't know what side of the chest. And then any airway issues could also be something that could cause somebody to go in traumatic arrest and or be in PEA. When somebody's in PEA and in traumatic arrest, it's likely a reversible cause that you might be able to fix. It doesn't always guarantee it. But out of the 4 things that I listed, how many of those things can we actually fix in the field? Well, we have blood, so we can give the patient blood. We have the ability to do finger thoracotomy, so we can help relieve any tension or hemopneumos. We don't necessarily have the capability to do pericardioenthesis, but we do have the ability to manage an airway. So if somebody's in PEA, that's an opportunity for you to potentially reverse a reversible cause. Now, when it comes to Lucas placement, the reason why we're not placing the Lucas right away is because the Lucas is going to block the landmarks that are needed for you to decompress or do a finger thoracotomy. Now, when the Lucas comes into play is after your initial treatment has been done and you've decided to ground transport. And the reason why I say if you decided to ground transport is because we don't necessarily want you guys doing CPR standing up while you're going emergency lights and sirens to a hospital. If you're already transporting, you should have already gotten all your initial interventions done. And what I mean by that is you probably should have already darted the chest. You already should have done a finger thoracotomy. All right, so I want you guys to think about what is your initial treatment plan. You're walking into a situation where the engine is doing CPR. You got PA on your monitor. The patient just recently coded according to bystanders. So we need to have a plan going into these calls. And really, I want you guys to have the same mentality for any severe trauma patient. And that's use your BAF assessment. That's what's written in our protocol. So the first thing that you should always do for any trauma patient is cut off exposed, look for signs of bleeding, okay? If there's any potential areas where they could have bled out from, because it may not be bleeding now because they could have lost all their blood, still put tourniquets on those areas. If there's wounds in the junctional area, wound pack those areas. Second thing I want you to do is put a firefighter, put an EMT on the airway. Have them put an eye gel in. It doesn't have to be ALS right away, obviously depending on the situation, but in most cases you can start off with an eye gel. Immediately, if you find any type of penetrating wounds to the chest cavity, put a chest seal on. And then because there's trauma to the thoracic cavity, or if it's blunt and you suspect trauma to the thoracic cavity, the needle decompression is going to be the best thing on both sides of the chest to help rule out tension pneumothorax. And the best way to find your landmark is take your gloved hand, put it right underneath their armpit area. Where your pinky lands is typically going to be that 4th to 5th intercostal space. If it's a male, you can use a nipple line. If it's a female, use the inframammary crease. So that's basically the junction where the breast and the armpit meet each other. And that should get you right in that area. Obviously, you don't want to miss too low, because if you're missing too low, you're hitting diaphragm, now you're hitting organs. So, and then H in the BAF assessment is going to be hypothermia. So obviously, we've been taught this in EMT school. Keep the patients warm, keep your trauma patients warm to help reduce that trauma triad. And then obviously, if they have any injury to the head, we want to elevate their head just to kind of help reduce any intracranial pressure. This is a video on our YouTube, which I will not show on the recording of this lecture, but it's very easy to find. It's on our YouTube page. It's from our cadaver lab on how a finger thoracotomy is performed. So I would highly encourage anybody to just jump on our YouTube page and look for it. It shouldn't be hard to find. So I want to play the what if game with you guys. What if this patient was in asystole and not PEA, right? So if you showed up and they're shot in the chest and you're working and the engine's working them, you put the pads on and they're in asystole. It's up to you at that point. Do you want to work them or not work them? Patient just recently coded, they're freshly warm. You know, they have one gunshot wound to the chest. You might be able to reverse that with a finger thoracotomy. You might be able to reverse that by getting some oxygen, you know, closing the chest wound with a chest seal. So every situation is different. But if they're in PA or in a shockable rhythm, they're taking that choice away from you because you need to go ahead and start working that patient and try to hit those reversible causes. And we'll talk a little bit about that here in a second. But if you decided to work the patient, just do your BAF assessment. Okay, control the bleeding, secure an airway, decompress the chest if there's any trauma to the chest, and do your best to keep the patient warm. If you do that BAF assessment and nothing has changed during your next pulse and rhythm check, they're still in asystole, you can continue to work the code, but you're allowed to call the medical director and ask for a field term. Okay. The reason why you're going to ask for a field term is because you did some ALS treatment if you did your BAF assessment, but you do not have to transport the patient if you decide to work them. Now, if you did take that patient and you started to work too quickly and you move them to the ambulance, then at that point, once the patient's in the ambulance, you have to go to the hospital. You really don't have a choice. And blood in this situation, if they're in asystole and you decide to work them, is really up to you. Just understand that if you don't have the ability to rapid infuse blood, it's going to take 10 to 15 minutes on a good day with a pressure bag to infuse that blood through an IO site. So if you're okay with sitting on scene waiting for that blood to go in for 10 to 15 minutes to see if there's a response, by all means do it. If you decide not to give blood to a patient who's in asystole that you just decided to work just to see if you can hit a couple reversible causes, then that is completely your choice and your judgment call. So transport destinations. Obviously, you can always consider air medical. I do think that this really should depend on the time of day. If you're working a traumatic arrest at 5 o'clock in the evening, it might not make sense for you to go by ground because that could take an extended amount of time to get to the medical center. But if we're working a traumatic arrest in early morning, aka middle of the night, on a weekend, it may not make sense to fly this patient. And not every patient needs to be flown. And that, again, that really just depends on the time of day. And I think we've just got into the habit of calling life flight for everything that is usually indicated for as far as severe trauma. But if you are not fixing the patient with your reversible causes in your initial treatment, more than likely that patient is not going to survive. And we're possibly taking a helicopter away from the community to transport a patient who's going to immediately be pronounced in the ER. Ground transport. Now, Dr. Stevens would still prefer to you to go to a level 1. That could be either Memorial Hermann or Ben Taub. But if you happen to be in 3's territory and you're working a traumatic arrest that does have CPR in progress, you are allowed now, because we just added it back into the protocol, for you to transport to Memorial Hermann Katy. Now, on the off chance that that patient gets pulses back while you're en route to Hermann Katy, you can always meet life flight on the helipad. So what you would do is key up on your radio, ask Westcom if life flight is available to rendezvous with us at West Base, and you can hand that patient over the life flight so they can take them to the appropriate hospital. But if they remain CPR in progress, transporting to Memorial Hermann Katy, depending on where you're at in the territory, might make sense for the situation. Summarize it: if you show up and they have injuries incompatible with life, even if the engine's doing CPR, you as an in charge can call DOA. If at any point the patient codes in front of you, so you show up and they look peri-arrest, like they're about to die, and they code, then just do the full traumatic arrest protocol. That means blood and transport. Unwitnessed arrest, asystole, and you decide to work them, again, just do your BAF assessment. Blood is really depending on you guys as the providers. And then if no change, you can contact your medical control, which is Dr. Stevens majority of the time, and ask for a fill term. Any rhythm change from asystole to PEA, you're going to give whole blood and transport. So if you decide that work that patient in asystole, you get an airway established, you dart the chest, and then all of a sudden your next rhythm change, you're in PEA. That's enough for you to be able to justify the transport this patient, because there's something that you hit in a reversible cause, and now we probably need to start infusing blood into that patient. Unwitnessed arrest, so you show up, kind of like our case study, and they're already in PA when you get there. Just go ahead and do your traumatic arrest protocol and start moving towards the hospital. And again, like I said a couple of slides ago, if you get pulses back, you can meet life flight on the helipad if you're already en route to her. All right, so I'm going to be reviewing hydralazine, which is going to be a new medication that we're going to add to our protocol. The goal is to get this on the ambulance by December of 2024. But the way hydralazine works is it causes vasodilation, and vasodilation is going to lead to a drop in blood pressure. Now, when you are pulling this medication out, just like labetalol, you have criteria, you have things that have to meet the indication mark. With labetalol, you had to call Dr. Stevens because people forgot about the beta blocker. He was worried that people were forgetting about the beta blocker properties of the medication. Hydralazine does not lower heart rate, so you do not have to call Dr. Stevens. I will caution you in that not every single patient do we need to be aggressive in treating hypertension pre-hospital. Try to do your best to stick to the indications, which is systolic above 200 and or diastolic above 100, in addition to being symptomatic. So if their blood pressure is high, but they're not necessarily symptomatic from it, we probably do not need to treat that in the field. There are other ways the hospital can address that. But if they do have that side of altered mental status, they do have that suspected stroke, they do have a severe headache, this is going to be a great medication to kind of help with those situations. Preeclampsia, which got cut off in this PowerPoint slide for some reason, is also an indication that for hydralazine. Mag sulfate is still going to be your front line, but hydralazine could also be used in addition to magnesium sulfate to help control blood pressure if mag is not doing the job. We still will be carrying labetalol. We may end up weeding out labetalol as hydralazine is implemented, but you may opt for labetalol in certain situations, and I'll kind of talk about that in the next slide. So hydralazine is typically a medication that is not commonly used in patients who are having an acute cardiac event or they have an extensive cardiac history. And the reason why that is because it can cause reflex tachycardia when you administer it. So if they are having that acute cardiac event, increasing heart rate could just increase demand and workload on the heart. So it's just something that you need to be mindful of. Acute cardiac events with hypertension, nitro is probably going to be the better option in most situations, as long as there aren't contraindications for nitro. If you do have a patient who is already tachycardic and hypertensive, and they're having signs and symptoms that meet the protocol to treat the hypertension, aka your hypertension, your severe headache, your stroke, your altered mental status patient, your preeclamptic patients, labetalol might be the better option in those situations because it won't cause that reflex tachycardia. If anything, it will cause that beta blocker effect, which will help lower heart rate, in addition to lowering blood pressure. Labetalol is still going to be a medical control consult, so you will have to call Dr. Stevens for those specific circumstances where they are tachycardic and hypertensive. I did add in our protocol for this specific drug, the pregnancy class, just so you guys can have an understanding of how this affects mom and baby. And then I added in some notes, and these are important notes because anytime you have the ability to lower somebody's blood pressure, uh, you need to be very cautious about it. In addition, if you have somebody who's intubated and potentially is having a stroke, and that's what you believe you intubated them for, you don't want to push a bunch of medications all at one time that could severely drop blood pressure. So if you have that intubated patient and you're suspecting hemorrhagic stroke, prioritize sedation first. What that means is if you intubate them with fentanyl versed, obviously get the tube. The minute after you intubate them, get a blood pressure. See how many points their blood pressure has dropped with the intubation attempt and the medications you pushed. If they didn't have a drastic drop in blood pressure and they're still hypertensive, then go ahead and add in some more fentanyl versed. One, as a post-intubation sedation, and two, it can inadvertently help lower the blood pressure down to appropriate parameters. Now, if you maximize your sedation and the patient still remains severely hypertensive en route to the hospital, we know that our blood pressure goal, which is at the very bottom, should be between 130 and 180 for your hemorrhagic medical stroke patients. So, if they're still hypertensive, then you can start titrating in some hydralazine at that point to help lower the blood pressure. What you don't want to do is push a bunch of sedation medications and your antihypertensive medications all at one time, because that could lead to a severe unwanted drop in blood pressure. So your concentration for the vial is going to be 20 milligrams per ml. Our goal is to push 10 milligrams at a time. Dr. Stevens is going to want you to take this vial, dilute it into a flush. So squirt out 1 cc from the flush, draw up the entire vial. Basically, that gives you a concentration now of 2 milligrams per ml. So you're going to be pushing 5 mLs at a time. So once it's diluted into a flush, 5 mLs is going to be 10 milligrams. And the reason why he wants you diluting it into a flush is because it allows you to be able to have more control and allows you to be able to give this medication over a slower period of time. The faster you give this medication, the more unwanted side effects possibly could come. So it's just better to dilute this into a flush so that you have more control over it. And then you are able to repeat this up to 4 times, which is going to get you to that max of 40 milligrams. Be cautious. You never completely want blood pressure to be normal in most patients. And normal textbook-wise, 120/80. So if you started at 220, your goal is to not drop the blood pressure 100 points. We don't want more than a 20% reduction in blood pressure. So depending on the situation, if you get a 10-20 point drop, that's probably enough and we need to stop. And then obviously continue to monitor. If the blood pressure jumps back up and you haven't hit your max dose yet, you can start titrating in a little bit more. But just be cautious treating blood pressure in the field. We're not trying to get it to a perfect number. We're just trying to help either alleviate symptoms or get it into appropriate range for our stroke patients. All right, if you guys could scan the QR code, this will take you to a quiz. It will show compliance and help us move forward with getting this medication added onto the ambulance. Please reach out if you have any questions, if anything was not clear. You should know my phone number. You should know my email. Thank you.